السلام عليكم ورحمة الله وبركاته، والصلاة والسلام على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. إن شاء الله اليوم هنكمل كل التريكات around إزاي تعمل بري ترانسبلانت ورك اب or to assist any patient with endocrine disease to be ready for kidney transplant. اليوم التوبيك زي ما احنا عارفين هنتكلم على كل التريكات. طبعا هي هتبقى كذا توبكس وكل توبك هيكون مختلف عن التاني، وفي النهاية انت ممكن تجمع البروتوكول وتعمل بروتوكول لنفسك تحطه في المكان اللي انت فيه، او تشوف التريكات او تشوف الحاجات اللي هي ممكن تظبط بيها بروتوكول عندك وكده. حد موجودة معايا بي دي اف، لو حد عايز أنا في الكومنتات برسلها لكم على نفس التوبك. والله المستعان. ان شاء الله نحاول نحضرها بي دي اف ونحطها في الكومنتات بإذن الله. نتوكل على الله عشان الوقت. بسم الله توكلنا على الله. ال goals of pre-kidney transplant or transplant assessment for our recipient. عشان تختار تعمل selection who is the patient appropriate for a candidate for kidney transplant recipient. adequate. يعني تعمل بريبريشن للريسيبيانت بحيث ان انت ما بتمزد اي شيء خاصه في الانفكشوس ورك اب والكارديولوجي ورك اب مالجنس ورك اب. لازم تعمل اديوكيشن للفاميلي اند الكير بروفايدر. كير بروفايدر اللي هو مثلا انترنال ميديسين او جنرال نفرولوجي refers this patient for you as a kidney transplant. You should do education for both and the care provider through your letters or clinic assessment after the first clinic assessment for your recipient. And try to maximize the chance for success of recipient to be candidate for kidney transplant. Try to do your best and try to manage, for example, his body weight, volume assessment, to give a recommendation for the primary team caregiver or whatever general nephrology to just control, for example, body weight, diabetes, hypertension, volume assessment, anemia, and detection of medical surgical condition and should be treated before transplant. Outline risk versus benefit طبعا of kidney transplant, like playing the bad guy. نشوف الكلام ده كله دلوقتي. What is the pre-transplant assessment؟ طبعا البري ترانسبلانت بيحصل في الكلينيك عندك. ممكن لو انت مثلا على حسب number of the patient maybe you can do one clinic a week or two clinic a week. At least each patient need at least 1 hour. Patient is encouraged to bring his family members. It's more is better at least to be sure this patient have support after transplant for clinic follow-up and the medication after, and to give, especially for high cardiac risk patient, malignancy risk, whatever, at least if one missed, the other will not miss. It's better to collect more family members during the first transplant session for assessment for workup. And reading materials ahead, and you can search in Google or whatever, and you can give him some pamphlet for kidney transplant introduction. Meeting with physician, nurse, social worker, other patient request, like all like multidisciplinary team, professional translator. Some patient can't understand, can't speak English or another language, or better to bring one other translator. And also the more family member, it will be good for assessment during the pre-transplant clinic assessment. Prior to the transplant clinic visit, we need just a referral note from his dialysis doctor or nephrology doctor by all demographic and the patient history, renal history, and examination and labs. And yes, we have this form already. We discussed in the first lectures already. For assessment for any patient transferred from dialysis to the kidney transplant. We have parameter he should fulfill as he can all this parameter to delay the waiting time for kidney transplant. Nursing and social worker notes should be mentioned for the kidney transplant physician before the first clinic visit, at least to be sure his patient is socially is okay as regard his house, mobility, functional employment, drug coverage, and recent blood work and other investigation to give alarm to his primary caregiver if he need just to control any blood errors. and discussion between nurses and identification potential live donor. Any live donor who is this patient or not, just will keep him on the waiting list. Other special investigation may be requested in advance, and like routine blood work, and the priority given to the recipient who is living donor. طبعا living donor ده بيبقى ليه البريوريتي. والبريمبتيف، البريمبتيف اللي هو لسه ما بداتش دياليسيس، والليفنج دونر طبعا ده بيبقى لهم البريوريتي عن الديسيز، لان الديسيز كده كده منتظر، لكن الليفنج لو عندك ليفنج طبعا بتحاول تزرعه بأسرع وقت ممكن before any complication or infection. What is the practical aspect in evaluations? Primary goal to protect the patient health. Transplant must have a positive impact on the patient overall health status. As we mentioned before, increase patient survival, quality of life, travel, food, drink. Standard may different from based on center to center, patient to patient need. Testing and evaluation can be prolonged. Multiple visits may be required. Some tests may become outdated, like echocardiogram, maybe stress test or stress test. All this should be updated, and CT iliac blood vessels. Intervening illness can produce new requirement and assessment if any infection or whatever, like catheter-related bacteremia, Staph aureus, need echocardiogram to rule out infective endocarditis. This, for example. What is the main indication for transplant? We discussed this in details in the first introduction lecture. End-stage disease, whatever the cause, is the one indication for kidney transplant. Mostly diabetic nephropathy, primary or secondary GN, hypertensive nephrosclerosis, and polycystic kidney disease. Less common, interstitial nephritis, reflux nephropathy, congenital neuropathy, Alport syndrome, and very good or excellent survival prognosis. هذه هي الانديكيشن main indication any end-stage renal disease whatever the cause is indication for kidney transplant. What is absolute contraindication? Malignancy, but it's the first one, not only malignancy, active malignancy or metastasis, but malignancy treated with covered the wait time after treatment can be transplanted with close monitoring. Active chronic infection not resolved, also another contraindication. This is the main two indication, mainly severe extrarenal disease should be in quiescent or remission. Demonstrate non-compliance, non-adherence should be delayed until he will be treated with psychology or psychiatric and social worker. Psychiatric illness also should be until cured. Active substance abuse and he's not compliance or adherence to discontinue this medication. Severe esophageal motility disorder, gastroparesis, active peptic ulcer disease, all this not absolute contraindication, but if cleared, it can be transplanted after that if cleared by GI. Malignancy and transplantation, no survival benefit. Life expectancy may be shortened, but adverse effect of immunosuppression on natural history of the cancer. Pre-transplant screening for asymptomatic cancer is important, may be helpful. Divine post-transplant immunosuppressive medication strategy. If cured, divine the tumor-free waiting period time required. ده بالنسبة للمالجنسي. طبعا احنا قلنا لو العيان عنده مثلا malignancy during the workup and he's treated and excision done, treated whatever chemotherapy, radiotherapy, and he's cured and covered at least 2 years, 5 years according to the type of the tumor, he can be transplanted and is little bit better survival because if he is waiting on dialysis, it will be more cardiovascular risk, benefit, infection, whatever. All this cause increases mortality on dialysis. Also, dialysis itself, the risk for cancer, not only the transplant with immunosuppression, but survival, I'm sure, is better than keeping the patient on dialysis. And the cancer risk a little bit more with transplant in comparison by lower number on dialysis. And this tumor-free waiting period for transplant eligibility, and we'll discuss this in details in separate lecture, but superficial basal cell carcinoma or squamous cell carcinoma and completely excised with tumor-free margin, no waiting time. Very small cancer in the renal cyst and with nephrectomy, no waiting time. Other renal cancers, bladder cancer, prostate carcinoma, 2 years waiting time. lymphoma, solid organ tumors, 2 years waiting time. Breast cancer, melanoma, invasive cervical carcinoma, 5 years waiting time. Chronic infection and extrarenal disease, infection like osteomyelitis, diabetic foot ulcers, active tuberculosis, infectious pleural effusion, AIDS, divining illness, and chronic active hepatitis. AIDS, if is active and not covering the criteria, and we'll come to this in separate talk. But all this should delay the transplant until to be quiescent or treated or resolved. Extrarenal disease, cirrhosis, advanced congestive heart failure, COPD, peripheral vascular disease, degenerative neurological disease. All this also should be treated or resolved before transplant. Poor adherence will delay the transplant until this patient compliance to his medication, his dialysis, common cause of late acute rejection, common cause of late graft loss, expense rarely in an issue in Canada, increase risk for graft loss, pattern of on dialysis when you will see your patient لما تكون متابع المريض بتاعك على الدياليسيس and his non-compliance with high PTH, phosphorus, recurrent hyperkalemia, higher intradialytic weight gain, poor blood pressure, blood sugar control. These all alarming symptoms. This patient not adherence, not compliance, and he will not working well with your transplant. Social factor very prominent and need to be explored in depth by social worker, psychiatry, psychology to be cleared before transplant. Psychiatric illness, psychiatric assessment is the part of the social worker mandate. Referral to psychiatrist occasionally necessary. Absolute contraindication, delirium, dementia. Relative contraindication, severe mental retardation, autism, and alcoholism, illicit substance abuse. Main concern is adherence post-transplant. Occasional episode of steroid-induced psychosis seen already. Most of this patient we can induce by ATG, thymoglobulin, and we can do rapid steroid withdrawal. Relative contraindication, chronic gastritis, chronic pancreatitis, and pancreatic insufficiency, esophageal motility disorders, unstable seizure disorders, multiple prior cured malignancy, medically managed severe coronary artery disease, advanced age, morbid obesity or severe malnutrition, severe osteoporosis, severe obstructive sleep apnea, and high quality of life in patient with increased preoperative risk. This all relative contraindication should be just treated, resolved, minimized before the transplant, but all this patient can be transplanted with the risk and the consent in details discussion with your patient and the relative. History and physical examination. Any patient who will come to your clinic, you should know end-stage renal disease cause, what is the primary kidney disease, any renal biopsy done, any report available is important for recurrence after transplant to know what is his primary GN. And current medication, any immunosuppression, any antiplatelet, any anticoagulation, adherence issue with medication, with dialysis, with his body weight, with blood pressure, with diabetes, allergy history. Is this patient allergic to sulfa, for example? It is important because we need BGB prophylaxis and UTI prophylaxis after transplant, either by dapsone, pentamidine, and atovaquone, or just to be sure, this patient, what is your prophylaxis after transplant and antibiotic prior surgery, prior surgical wound. During the surgery, what type of antibiotic we will give him if he's allergic to ampicillin or cefazolin, just so can give vancomycin. Rate of renal disease progressions is important. We discussed this before. Yes, you can ask your patient from the first clinic when the first time you heard about your kidney or chronic kidney problem or kidney problem. From that date until the date of dialysis, you can imagine or you can calculate the risk of progression or recurrence after transplant. If it is rapid RBGN, rapid progressive chronic kidney disease, it will mean this high risk for recurrence after transplant. We should close monitoring his urine analysis, especially for protein, and urine ACR if needed, and 24-hour if needed, and the biopsy as needed. And duration on dialysis also is important, longer duration. a lot of atherosclerosis will be happening. We should check his CT, iliac blood vessels, Doppler blood vessels, and the cardiovascular risk, dialysis access, and any complication with dialysis access, hemodialysis, what is thrombosis in a frequent clot, to ask for thrombophilia screens, an infection recently, to delay until clears the infection, any more workup needed, especially if staph aureus or whatever, enterococcus or enterobacter. Just all this need sometimes echo to rule out infective endocarditis, especially with spices organism. And dialysis complication with peritoneal dialysis, you should ask your patient, you have any peritoneal dialysis before, exit site infection, tunnel infection, and you ask for dialysis working well or no. Family history of kidney disease, especially for genetic one, like primary oxaluria, history for stones, GN, recurrence, whatever. Just to be sure you cover this part. Family history of diabetes, cancer, also to expect this risk will be higher post-transplant. Claudication, exercise tolerance, to be sure his patient have just a vascular anatomy is okay, no atherosclerosis, diffused either peripheral vascular disease or cardiovascular. Clotted AV fistula is important, vein thrombosis, miscarriage, just thrombophilia screen, antiphospholipid to avoid graft thrombosis post-transplant. Urine output, this is a residual urine output post pre-transplant is important to manage your patient after transplant. If it's anuria and he's making 1 liter urine, is a good sign. This is a good working kidney. But if it's no urine, just make it alarm for you. And you should do stat ultrasound, Doppler to rule out any surgical complication. And the target weight is important to see his patient his over, under, and what is the blood pressure also. You should ask for this to be fixed for his medication dose after transplant. Smoking history, and for BMI also, because we have some limitation for patient if it's abdominal obesity and the BMI more than 35 now. It should be treated first. Most of the patients started now Ozempic, 0.25 milligram subcutaneous weekly for 4 doses. And after 4 doses, we can increase to 0.5, to 0.75, and 1 milligram subcutaneous weekly, according to the patient tolerability. But Ozempic, keep in your mind, you should ask your patient he didn't have any pancreatitis before or didn't have any thyroid cancer before prescribing any Ozempic. GLP-1 inhibitors, you should rule out pancreatitis and cancer thyroid. Smoking history should, as I mentioned before, smoking should be stop or discontinue or quit smoking because the kidney will be more atherosclerotic and the graft survivor will be affected with the smoker. BMI, as we mentioned, and any abdominal surgery before for adhesion post-transplant, cardiovascular system examination, and the cardiac clearance is the main part of the workup. And the peripheral pulse, if you feel peripheral pulse, it will make you assured and comfortable for proceeding for kidney transplant. What is the routine investigation blood work before for patient in dialysis? Now you need just send. You should have CMV, ABV, HIV. 3 HIV, hepatitis B, hepatitis C, HTLV 1 and 2, also tuberculosis, varicella, MMR. CBC with differential is important also for anemia and others. Calcium, liver enzymes, all, and INR, BTT, BTH, iron saturation, PSA, the cancer screening, or radiocholesterols test, sickle cell screen, and the blood group, sensitizing history, blood transfusion, pregnancy, preface transplant, CPRA, class 1, class 2, cumulative, PPD skin test or IGRA, interferon gamma, assessment for tuberculosis, and 12-lead ECG, echocardiogram, cardiac stress test, exercise, perzentin, thallium, dopamine stress echo, abdominal ultrasound, sometimes pelvic ultrasound for females, iliac Doppler, and CT iliac pelvis without contrast to assess iliac atherosclerosis, mammogram and pap smear for female, fecal occult blood and fit test plus or minus colonoscopy if all this test was positive, fecal occult blood and fit test. And see panel reactive antibodies like CPRA and tissue typing also to assess how many mismatch between the donor and the recipient. coronary angiogram as needed, by cardiology assessment, sickle cell screen, especially with stress test positive. Patient should go to coronary angio as either for PCI or just diagnostic. Sickle cell screening, sleep study, upper GI endoscopy, fibroscan, plus or minus liver biopsy. Usually, if hepatitis B or hepatitis C is positive, you should do fibroscan plus or minus liver biopsy as needed. Avoiding cystogram if a patient has this any problem on his neurogenic bladder or whatever. Avoiding cystogram is important. TSH and other hormone panels to be sure hypothyroidism is under control. This is a mandatory also. 24-hour urine collection protein, especially for GN to expect recurrence post transplant, and pharmacokinetic profiling of immunosuppression medication also. And the PK virus, hepatitis B, HCC, PCR should be requested as needed. Pre-transplant native or transplant nephrectomy. What is the indication of native kidney nephrectomy? Massive polycystic kidneys, no space for the new donor kidney. Malignancy should be out, and chronic renal parenchymal infection, recurrent infection, infected kidney stones, intractable hypertension. All this absolute contraindication for or indication for transplant nephrectomy before prior graft loss due to BK virus nephropathy and the persistence BK titer by PCR, multiple third or fourth kidney transplant. وما فيش عندك سبيس برضه هتحاول تشيل الكدني. Combined kidney, other organs, we have kidney, pancreas together, and combined liver, lung, heart, whatever. Nephrotoxicity to prolonged calcium urine, especially with lung transplant. They have target level above 15 already. Most of the patient with AKI after lung transplant, but we know the lung transplant no other option. Glomerulonephritis with liver disease you should go ahead, and failing other organ transplant with simultaneous kidney failure, chronic kidney disease in candidate for another organ transplant, and hereditary oxalosis. With a combined kidney transplant with other organ, pancreas, liver, lung, heart, and also all together most can be simultaneous or one after one. It depends on the availability of the donor organs. Some special caveat based on intestinal disease etiology like systemic lupus, less than 10 milligram per day prednisone, clinical and serological question. Also is another indication it will be accepted for kidney transplant. Antiphospholipid syndrome based on the history, obtain hematology referral. You should do hematology referral for this one. And for systemic lupus should be quiescent at least 6 to 12 months, and at least less than 10 milligram prednisone, it will be okay. Focal segmental glomerulosclerosis, TTP, high risk for recurrence. Put this in your mind. Anti-GBM disease, a titer should be undetectable before planning to activate on transplant. Albor syndrome, rigorous liver donor screening may be developed de novo. Anti-GBM, live donor. Yeah, that's if you have live donor relative with Albor syndrome, you should just aggressive screening, and this patient should expect is around 5% develop anti-GBM disease post-transplant. Polycystic kidney disease, diverticulosis, you should ask for this diverticulosis, any history of diverticulosis, intracranial aneurysm by MRI, and screening also live donor if relative. Source of the kidney, either live kidney donor or deceased donor kidney, biologically related for life, emotionally relative or unrelated, or paired, common, a change, maybe a paired kidney donation also. We'll come to discuss with all this in details in a separate talk. And deceased kidney transplant, either standard criteria donor less than 60 years without any other comorbidities. Extended criteria donor, as we mentioned, more than 60 or less than 60 plus hypertension, CVA, and AKI or CKD. Donor after cardiac death also is another change, and the list change also. We'll discuss this in detail in separate talk. Waiting time of deceased donor is different from place to place. According to the blood group, they will depend, especially for recipient waiting for deceased donor is different, because you see some blood groups here like A and B at around 7 to 9 years. Other blood groups like also and AB less than 1 year because it's general receptor already. Usually this between 3 now to 9 years waiting time to get as a kidney in the waiting list. Outcome of kidney transplant, cause of loss. Cause of death with graft function, mainly cardiovascular here. يعني cardiovascular infection and malignancy. These are the three most common cause of death with functional graft, either cardiovascular here, 36%, infectious sepsis, 18%, malignancy is around 9%, followed by others. And unknown around 17% already. But this is the most common three causes here. And cause of graft loss more than 6 months, death with functional graft, as we mentioned, 53%. And chronic rejection, either acute, chronic, and GN already, and others 5%. This is important slide also, cause of death with functional graft, cardiovascular, infection, malignancy, and other unknown causes, sometimes stroke, GI disorders, accident, suicide, and 10% others. Causes of graft loss more than 6 months, mainly this with functional graft, and followed by chronic GN, followed by glomerulonephritis and others. Cardiovascular mortality after kidney transplantation in comparison by general population. General population here lower cardiovascular mortality in comparison by dialysis people here, and in between transplant is better than keeping the patient on dialysis. Same here, cardiovascular while waiting for kidney transplant, while prolonged waiting time, it will increase this cardiovascular death and mortality. Risk reduction through screening for coronary artery disease. During screening, identify and revascularize any coronary artery stenosis, reduce mortality, morbidity, protect the allograft already by good perfusion, and no more bleeding. Identify the high-risk patient, manage the risk patient, exclude patient short expected survival from home, kidney transplant not expected to be adequate benefit. Some patient came to the clinic after cabbage and the multiple comorbidity, and they looking for transplant. And just as these need family meeting, and you can sit with the patient, explain the risk benefit and the expectation who will die on table. But some patient will either I will die on table or get rid out of dialysis. And post transplant malignancy, this is already will be separate talk. جست كل الكلام ده كله نبذات مختصرة عن المواضيع، لكن بعد كده كل حته نتكلم عنها بالتريكات والتفاصيل اللي اتعلمناها هنا. Risk is higher than dialysis, but it's difficult to. But cardiovascular infection is better than keeping the patient on dialysis. But little bit small risk, but when the patient will be under screening already. Pre-transplant malignancy increase the risk, especially if have history of kidney cancer before. Most common cancer is squamous cell carcinoma, non-melanoma skin cancer, with basal cell carcinoma. Highest relative cancer is Kaposi sarcoma. All tumors have been described. Patient who is EBV zero negative or EBV mismatched donor positive, recipient negative, they need special counseling before transplant, and better to avoid aggressive immunosuppression like ATG or thymoglobulin for EBV mismatched donor positive, recipient negative. Take care from this. We should be antibody, just not only IgG. It should be antibody also positive to be sure he's EBV positive. Sirolimus may be protective for some patient. Just transfer the patient from the routine immunosuppression to mTOR's inhibitor. It will help to anti-angiogenesis and decrease the tumor progression. And everyone knows the medication safe with pregnancies like azathioprine, cyclosporin, mycophenolate, little bit nephrogenic with the congenital anomalies. Sirolimus, not much studies. Tacrolimus can be safe, and cyclosporin can be taken with pregnancy. Donor option, either live donor, standard criteria, extended criteria donors, exceptional distribution donor, estimated wait time between this and this. Better to take ECD kidney, extended criteria donor kidney. Better to waiting for a standard criteria donor for a long time. And CBRA also, if highly sensitized patient, as we mentioned before, it will be like 100% CBRA, cumulative binary reactive antibodies. If 100% is difficult to find donor for this recipient, it means highly sensitized patient. And risk discussion, pre-operative risk should be discussed. As we mentioned before, what is the complication around the surgery, immunosuppression complication, infection, malignancy, whatever, and the rejection outcomes, and the disease recurrence for GN and others, and the post-transplant follow-up expectation. And transplant already is a multidisciplinary team between pharmacists, nephrologists, surgery, infectious disease, cardiologists, psychiatric, social worker. All this should be a team together to clarify this patient is candidate for kidney transplant recipient candidate or no. This depends on clearance from all these subspecialties. ونكتفي بهذا القدر اليوم، ولا تنسونا من صالح الدعاء، ولا تنسوا الصلاة والسلام على حبيبنا محمد صلى الله عليه وسلم. والسلام عليكم ورحمة الله وبركاته، ونلتقي بفيديو قريب إن شاء الله عن more tricks around pre-transplant assessment. شكرا جزيلا، والسلام عليكم ورحمة الله وبركاته.